This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Thank you for joining us back with Osher Mini Medical School. We're continuing to talk about your medications, treatments, benefits, and risks. My name is Laden, and I am an emergency medicine clinical pharmacist right here at UCSF. Some people in the community may not know that clinical pharmacists actually work in the hospital. And if I had to boil down to a few words what I actually do in the hospital, probably a couple of things. One would be making sure that all patients get the right medications. We get them to the right patient and we get them on time. And the second part is clinically supporting physicians, nurses, and patients when it comes to medication safety, which includes preventing adverse drug events and medication errors. And those are the two things I wanted to talk to you about today. Since we're going to be talking about a lot of medications, which are brand name medications too, I have no conflicts of interest with any of the manufacturers. In the second part of the lecture, we're going to be talking about the research that was funded by the American Society of Health System Pharmacists, new investigator research grant. So let's begin. And we'll begin with a case of priapism. Now, by definition, priapism is an erection lasting more than 4 hours. And we had a patient who came to the emergency department after 5 days of having an erection. When he presented, he was in extreme amount of pain. And on examination, the penis was very swollen and very blue and bruised. The only past medical history that this patient had was that he was HIV positive, and he was on a cocktail of HIV medications, 4 of them, which is a common practice for treating HIV. The labs that we look at when somebody has an HIV infection are the CD4 count, which tells us how well the immune system's doing. And his CD4 count was 800, which is pretty comparable to patients who don't have HIV. So patients without the HIV virus, this is a normal CD4 count. The other laboratory value that we look at is the viral load, and this tells us how many copies of the actual virus are located in the patient's blood. And using the diagnostics available to us today, we found that this patient had an undetectable levels of the actual HIV virus. So this tells us a couple of things. One is that this patient is a very compliant patient with his medication regimen, that he takes all 4 of his medications that is instructed, as his lab values reflect that as well. So what happened? Why does this patient have 5 days of priapism? So 5 days earlier, as we gather more history, this patient said that he went out with some friends and he wanted to have some fun. And he went to a local head shop and bought a Chinese herb supplement called the Africa Black Ant, which is advertised as a medication for erectile dysfunction. Now, just looking at the back of the package, it's very sketchy, starting with the 2 Australian flags at the bottom, which is probably a typo. And then looking specifically at the instructions, the way that they're written, for example, date of production, introduction. I don't know what that means. So we went to the store where the patient bought these medications, this supplement, and we bought a packet, and we took it to our poison control center, and we had it analyzed. And what we found was that whoever made this drug took a pill of Viagra, sildenafil, crushed it, put it in a capsule, and sold it as this exotic supplement that, for erectile dysfunction. Unfortunately, a couple of things happened with this patient that were very interesting to us. all medications are considered poisons by our body. So liver works very, very hard to get rid of them as soon as they can. So the HIV medications and sildenafil, the liver will try to get rid of. Unfortunately, some of the HIV medications slow the liver down when it comes to getting rid of these toxins out of our body. And unfortunately for this patient, the enzymes that are slowed down by the HIV medications are the ones that are responsible for clearing out the sildenafil. So what ended up happening is that instead of the body getting rid of Viagra in 6 to 8 hours, it took the body 5 or more days as the Viagra hung around in the body. So I went onto the Viagra's website to look at kind of some information that they provide. And this last line, there's actually a warning by the manufacturers that states if you're taking certain HIV medications, your doctor may recommend a lower dosage starting with 25 every 48 hours. And our patient ingested 100 milligrams of Viagra. And then there's a couple of interesting things on Viagra.com. First one being they're very proud that 22 million men have taken this drug for erectile dysfunction. And I don't know what a good-looking 55-year-old man with a wedding ring kayaking has to do with erectile dysfunction, but it is advertising. But probably the thing that's very concerning to me is this statement here, which states that if in a rare event of erection lasting for more than 4 hours, and I'm sure all of us have heard this on the advertisements at night, please seek immediate help to avoid long-term injury. So I just wanted to share with you what happens when somebody has priapism and seeks emergent care in the emergency department. So the treatment of priapism is not benign. There's a lot of things that go into it. Historically, we've tried oral medications, which we found it don't work really well, and some guidelines are actually discouraging using oral medications today. The next thing that happens is that the physicians will inject 2 needles on either side of the penis, and they will inject a very potent drug called phenylephrine. Phenylephrine is a drug that we usually use for very, very low blood pressures, and the concentration that we use for priapism is 5 times more concentrated than we would use through a vein to raise somebody's blood pressure. So the medication will get injected, and then the blood will be aspirated in the hopes that the penis will detumesce or that it will go down. Unfortunately, not even this works many times, and the only thing that's left to do is surgery. But one caution about this drug, phenylephrine, what can happen if this drug is absorbed systemically, it can have systemic side effects, and there are case reports of patients having heart attacks and strokes because of the treatment of priapism using this medication. So the last option is surgery. And before the surgeon comes down and performs the surgery, the penis is injected with lidocaine, which is an anesthetic that similar to what the dentists use. And mind you, all of this is done in the emergency department. These patients are not taken to the operating room, and this is done while they're awake, just with local anesthesia. The surgeon makes 2 incisions into the cavernosal bodies where the blood is that's causing the erection, and they twist the scalpel and go ahead and squeeze the blood out of the penis to finally for the penis to go down. Unfortunately, even this sometimes does not work, and this procedure has to be repeated. Now, one drug causing so many complications is basically what we call an adverse drug event, with all these events, subsequent events that followed, placing the patient at risk for other things, such as infection from the surgical procedure and adverse drug events from the drugs that we use for priapism. So I think this should be included in the evening commercials saying that if your erection lasts than 4 hours, there's a small chance that this may happen. So I want to talk about reaction versus event versus error, because healthcare providers, including myself, have gotten this confused many times and use it interchangeably. So if we talk about the adverse drug reactions, these are reactions that are caused by medications that are usually known to us, and they come out during clinical trials. So a patient taking his medication as prescribed has an adverse drug reaction, and this is what an adverse drug reaction is. It should not be confused with an adverse drug event. All adverse drug reactions are adverse drug events, But an adverse drug events are basically harm associated with direct or indirect use with a medication. So for example, a patient gets prescribed a medication for anxiety and goes for a drive, and the medication makes the patient very woozy and drowsy, and the patient crashes the car. That would be an adverse drug event from that medication. If the patient tries to commit suicide by drinking a full bottle of medications, also an adverse drug event. And the last thing on the list is medication errors. Now, medication errors are probably the most common medical errors that occur, and not all medication errors lead to adverse drug events and adverse drug reactions. But today, I did want to talk to you about these errors right here, where the Venn diagrams cross, about the medication errors that do lead to adverse drug events. So if we look at the prescription process, the medication process, how a medication gets from the prescription pad to the patient, there's a few steps that are involved in the prescribing of the medication, so cognitively interpreting the diagnostic test, deciding what therapy is best, and then writing for that prescription. That process in itself is also prone to errors. For example, diagnostic errors. If a patient is misdiagnosed, they can be placed on a medication that has significant harm, which they didn't need to begin with. Errors can occur with dispensing, usually done by the pharmacy, administration of the drugs, either by the patient or by a healthcare provider, monitoring of the medication regimen, and finally, communication between the healthcare provider and the patient, and vice versa. So, for the people here and also at home, if you can tell me what the first word says here, I'll give you the second part, which is 4 milligrams by mouth, an acronym. Question? So question is that Coumadin? So good. Is it Coumadin, or is it Avandia? Unfortunately, what makes this case very difficult is that Coumadin, which is a anticoagulant, a blood thinner, and Avandia both come in 4 milligrams, and they're both given by mouth. So this is a mistake that can be easily done because of handwriting. Fortunately, we're slowly moving away from handwritten prescriptions, although many prescribers still do write prescriptions by hand, but an easy mistake to make. Now, this mistake can go completely silent and unnoticed, but if somebody after surgery was to get Avandia and they received Coumadin, that could potentially result in complications with bleeding. So let's look at another example. Does anybody want to take a stab at this one? I'm sorry? So Zendel, okay. Let's make it multiple choice. So is it Plendil or is it Bentyl? So very hard to interpret. This is an actual prescription that ended in a patient death, actually, because of this prescription. This is a medication that was intended to be Bentyl, and in the United States, Bentyl is spelled with a Y, not with an I, but outside of the United States, they do spell it with an I. So the pharmacist that received this prescription read it as Plendil, which is a calcium channel blocker whose maximum daily dose is 20 milligrams. Whereas the patient just went to their physicians because they were having an upset stomach, and they gave him an anticholinergic medication, Bentyl. So what ended up happening, the patient started taking this medication, 20 milligrams every 6 hours as it was written, and he kept getting worse and worse, and 2 to 3 days later, he died from cardiovascular collapse from this medication. So handwritings have been implicated in medication errors, and interpretation of handwriting has been. Like I said, fortunately, we're getting away. We're having electronic ordering, which can cut some of these errors out. It does come with its own errors, but it can improve the handwriting errors. Unfortunately for this patient, he did pass away. So let's talk about July, because we're right in the middle of July while this is being recorded, and we cannot go around this topic. This is called the July effect in the United States. It's called the killing season in the UK. And basically, there have been some small studies trying to prove this, and there was a recent study in 2010 What they did, they went back for 40 years, from 1979 to 2006, and they looked at all death certificates and analyzed them. And what they found, that there was a spike in deaths caused by medical errors that occur in July. And when they looked at it further, they found that this was closely associated with teaching hospitals more so than community hospitals. Now, this can be very troubling in that what's being said here is that the July effect, or the killing season, occurs because July is the month where the new doctors start working, the new residents. They finish medical school and they start actually writing prescriptions themselves and caring for patients. The analysis found that medication errors spiked by 10%, and medication errors that result in death spiked 10%, whereas surgical errors did not spike. So one of the things that was being discussed is that surgery residents probably get a lot more one-on-one supervision from the senior surgeon, whereas general practitioners are taking care of patients by themselves. Now, I would not go and make a blanket policy that nobody should come to the hospital in July. I don't think this study is strong enough to make such a conclusion. For example, we're looking at 40 years worth of data, and if we look at how medicine was practiced in 1976 compared to, 1979 compared to 2006, many things have occurred that have improved medication safety. For example, every single prescription in a hospital that gets written virtually gets reviewed by a pharmacist. There are programs and software that help us detect medication errors before they happen, along with drug-drug interactions. But just an interesting finding that, that there is a 10% spike in mortality due to medication errors during the month of July. So medication-related errors occur very frequently. Like we said, most do not result in actual harm, but the ones that do are very costly, and they're costly to the patient, the family, and the healthcare system. If you just Google horror medication errors, there's a ton of anecdotal stories. For example, there's a recent one where a pediatric nurse in a neonatal ICU, instead of giving 140 milligrams of calcium, gave 1,400 milligrams, so just 1 decimal point off, which resulted in a patient death. Soon after, that nurse committed suicide. So there's a huge, huge effect on both the healthcare providers and the families involved when medications do occur. If you were to pick up a book or an article to read about medication errors, you're likely to come across these stats. And that is that between 50 to 100,000 patients die in the United States from preventable medical errors. About 7,000 of those are due to medication errors, 1 in every 100 or so outpatient deaths, 1 in every 900 inpatient deaths, and about 10% of people that come to the hospital because of an adverse drug event. So let's see where this data actually comes from. There's a really cool application on Google called the Ngram. It's not the most scientific way to study things, but if anything, it might represent our collective human consciousness. And what this program does is that Google has digitized about 5 million books. And if you put in a search string for a word, you can see how many times that word has been written about in the past 100 or so years. So I plugged in medical error and adverse drug event, and we can see that for the past 100 years, there really hasn't been a whole lot of literature published dealing with the subject. But something happens in the year 2000 that just skyrockets the interest in patient safety, medical error, and adverse drug events. Does anybody know what happened in the year 2000? Yeah, so there was a study. The Institute of Medicine published this book, this study, which basically looked at adverse drug events and medical error in general, and they found that this is a huge, huge concern. So those numbers that I quoted are coming from studies in the early 90s where they looked at these errors. So since the publication of this book, there has been a huge push, starting with the end of the Clinton administration, where they invested many resources into designing patient safety reporting systems and learning from mistakes and medical errors to improve healthcare today. One of the things that I really like about this report is the mention of human capabilities, and that if an adverse drug event or if an error occurs, it's not the end user's fault. It would be much like blaming a pilot for a faulty airplane crashing. So human capabilities was one of the things that was implicated in these things, and to respect human capabilities and design safety systems around human capabilities. So for example, we can't expect a nurse to take care of 10 very sick patients with the same intensity and make sure they get all the treatments necessary that they need without increasing the chance for error. So then, just for comparison, I looked at pilot error, and one industry that medicine gets compared to quite frequently is the aviation industry, and I think it's apples and oranges, but there are some lessons that are pretty comparable, and I think this is one of them, and that is that the aviation industry started respecting human capabilities about 60 years before we did, so they have a 60-year start on preventing events and pilot error. So just an interesting find from Google. So let's talk about the actual adverse drug events. So I pulled this report from the FDA, which is actually a database that was created because of the initiatives of this report, where any serious adverse drug event has to be reported to the FDA by the manufacturers, by the patients, and by the healthcare providers. Now, it is a voluntary service, so if anything, these numbers are underrepresentative of what's really happening out there. So the report between 2012 2013, there were about 56,000 serious cases reported involving medications, about 13,000 patient deaths. Now, these deaths probably cannot be attributed solely to medications. Many of these patients are involved in clinical trials, and these patients are very sick with things like pancreatic cancer, end-stage lung cancer, where mortality is really, really high. So these patients die while they're on these medications. That's why the report number can be 13,000, and about 2,600 possible medication errors. The thing that I found most striking was the most common adverse drug event that was reported recently was hypersensitivity, coming in at number 2, and at number 1, just some minor stomach aches and pains, nausea, vomiting, diarrhea, which is very common. So before we talk about hypersensitivity specifically and allergic reactions, adverse drug events, some of them are preventable. And if we look at the literature, there's numbers between 5 to 40% of all adverse drug events are preventable. The thing is that there's a significant number of adverse drug events that are not preventable that we know about, and any good clinician is going to take this into the risk-benefit calculation before they give the medication to the patient. So for example, let's look at the treatment of stroke. And before we talk about stroke, just a quick public service announcement. There is an acronym called the FAST, F-A-S-T. If you see someone who has acute changes in their facial expression, you ask them to smile, and one side of their face goes up while the other one droops, that could be a signal of acute stroke. If you ask them to raise their arms and one arm is either not moving or it's drifting, that could also signal stroke. And finally, speech. If the speech becomes acutely garbled and the patients are not making sense, that could also signal stroke. Any one of these symptoms from the FAST, there's about 72% chance that the patient could be having stroke, so they need to get to the hospital as soon as possible. The T in FAST stands for time to call 911. So, talking about ischemic stroke. So let's say you come across somebody in the public who's having these symptoms, and we call 911, they come to the emergency department. The following conversation is something that happens pretty much every day across the world when it comes to treatment of ischemic stroke. There is a medication that we can give you for ischemic stroke since you came in within 3 hours' time. The longer we wait for this medication, the less chance for it working and the more chance for harm. If we were to give you this medication, which is called TPA, which is a clot buster medication that breaks the clot causing the stroke, these are the risks and the benefits associated with it. If we were to give 100 patients who are having the type of stroke that you're having right now, this medication, about 30 of those patients would do better by receiving this medication. Most of the patients will not be harmed or gain any benefit from getting this medication. And there's a small chance, between 3 to 5%, that this medication might make you worse. 1% that can make you so worse or actually leave you severely disabled or cause death. Unfortunately, this is probably the patient's worst day in their life when they're having a stroke in their families. And unfortunately, we have to do the Vegas talk, which is talking about probabilities of our diagnostics and also probabilities of treatment. This is how we weigh the risks and the benefits, and we always pull the patient in to have their viewpoint and see if they want to take the risk of getting this medication. So, talking about adverse drug events, let's go back to the hypersensitivities and kind of let's look at which hypersensitivities were reported. So the first one on there is anaphylactic shock, which is a severe allergic reaction. There are severe cutaneous reactions that can also happen. For example, some common antibiotics can cause a cutaneous condition, a skin condition known as Stevens-Johnson syndrome, which basically the medication for some unknown reason ramps up the immune system, and the immune system starts attacking the skin, causing, starting with severe rash to actually peeling off the skin. There's also angioedema, which is the swelling of mucosal surfaces, or actually swelling anywhere in the body. Once again, we have these other severe reactions down here, and most of these patients, like we said, are those patients with high mortality due to their underlying disease. But let's kind of another PSA talk about anaphylaxis. So what is anaphylaxis? So it's a severe allergic reaction, and it occurs as a response to foreign substance. And that foreign substance can be food, it can be an oral medication, or it can be an injectable medication. And the way our body responds during an allergic reaction, it can involve one or more organ systems. We can get skin reactions, and there's a huge variability of skin reactions. It can just be a mild rash on the back of your hand, or it can be something like Stevens-Johnson's severe cutaneous reactions. It can also involve the respiratory system, as the anaphylaxis or the allergic reaction causes a lot of vasodilation, which causes edema in the lungs. So these patients can have a wheezy breath sounds, and their breathing can actually shut down from the edema of their throat, which can suffocate the patient. So it is a life-threatening emergency. And finally, the cardiovascular or the heart effects, since there's so much vasodilation that's occurring during this process, the blood pressure can plummet down, and patients can go into shock or anaphylactic shock, which can be deadly. So which medications from the FDA have been reported as being kind of the top 10 offenders when it comes to anaphylaxis? So the first medication on the list is a medication omalizumab, which brand name is Xolair. So this is a medication that's a monoclonal antibody. And if you ever look at medications and there's an MAB at the end, the MAB stands for monoclonal antibody. So it's an actual antibody that's being injected into patients. The two letters before the MAB are ZU, and this stands for humanized monoclonal antibody, where the genetic sequence is made more human, so there's less reactions from the body when this drug is injected. For example, there's another one on the list called infliximab. So once again, we have monoclonal antibody. The XI this time stands for chimeric monoclonal antibody, which is a mix of human species and another species to make the monoclonal antibody. So for this drug, the first one, Xolair, is used for asthmatic patients who have very high levels of IgE. And IgE is something that's implicated in allergic reactions and also severe asthma. And the way that this medication works is that it binds to the IgE, inactivating it. Now, this drug, we know that it's very dangerous, and the FDA knows that it's very dangerous because it can cause anaphylactic shock. The drug is actually black boxed against anaphylactic shock, meaning that patients need to be aware that upon administration of this drug, this could happen. And this is why this medication needs to be given at a physician's office in case there is an allergic reaction, that treatments can be started pretty quickly. The other drugs on here, we have actually a contrast agent that's used during MRI scans to kind of light up the vasculature of the brain. Another MAB, cetuximab, monoclonal antibody, Copaxone, used for multiple sclerosis. So many of these are actually drugs that are used in patients who have some type of an immune hyperresponse already. The ones that are not are the last four, which is amlodipine, Norvasc, medication used for high blood pressure. Many patients are on this medication. Ibuprofen, the aches and pain, Advil, Motrin, over-the-counter available. Lisinopril, another drug used for blood pressure, and then naproxen. So what's concerning is that these last 4 drugs are very, very common. Thousands, if not millions, of doses are dispensed of these drugs. But as you can see, there's definitely a risk of having anaphylaxis with any drug. So looking at anaphylaxis, let's talk about treatment, and that treatment is going to be epinephrine. We don't have that many medications in medicine that we can say this is a life-saving medication. Very, very few. Ones that come to mind, aspirin for heart attack, and then epinephrine for anaphylactic shock. So this is a life-saving medication. So if a patient is having a severe allergic reactions and they present to us, this is the first-line treatment that we're going to administer. Now, if you have an allergic reaction that's not severe and you come to the hospital or see your physician, you're likely to get prescribed what's called an EpiPen. And the reason for that is if this allergic reaction ever comes back, we want you to be able to treat yourself immediately and then call 911 and come to the hospital. So this is a medication that's prescribed to someone who has an allergic reaction to a substance to carry with them. Most commonly, children with peanut allergies, we will give this to the parents so the school nurse can have it and also the parents as well. Now, if you come across a patient that's having an allergic reaction and they have an EpiPen on them, I just want you to be able to kind of know how to use this. So let's just really quick go through this because it's kind of interesting. So this is an EpiPen. There's 2 things to remember about it. We have a safety catch, this blue thing, kind of like on a gun, a safety catch. And there's a needle down here that's actually spring-loaded. So when the safety catch is taken off and this senses pressure, the needle will come out and deliver the medication. So usually when I tell patients to give themselves an EpiPen, when we teach them how to use an EpiPen, I always tell them to hold the medications just as I'm holding it right here. Because many times, and even what I want to do by default, is stick my finger up there and hold that blue cap, or where the blue cap used to be. Unfortunately, when patients are in extremis and they're very anxious, what happens is that they will do this. They will take the pen and hold it upside down, and the needle, instead of going into the outer thigh as instructed, will go into the thumb. Now, needle going into the thumb does hurt, but it's not all that bad. What's really, really bad, it's the medication going into the thumb. If you think about your thumb, it's a very small area, and injecting such a potent medication will cause severe vasoconstriction. And when you have vasoconstriction, you limit blood flow to your thumb. And if there's no blood flow, there's cell death, necrosis, infection, and patients can lose their thumb. And the reason I want to share this with you, because every year we have half a dozen parents who come in who have not used the pen appropriately and end up shooting themselves instead of the kid. So just be careful with those out there. So we talked about anaphylaxis, a very allergic reaction, which can also manifest as angioedema. And we said angioedema is the severe swelling of mucosa or skin. So what we found is that lisinopril, which is an ACE inhibitor, is a great, great drug for blood pressure. And like we said, there's probably thousands to millions of prescriptions written for lisinopril every year. But there is this rare side effect that can cause angioedema, and this can be very life-threatening. The second drug on there is a combination pill, which has a water pill, the hydrochlorothiazide, and lisinopril as well. And most likely, it's the lisinopril that's the culprit, even in these case reports. We have another antibiotic medication for osteoporosis, more antibiotics, which are very commonly used in everyday practice, a medication for hepatitis C, and a few others. So what does angioedema look like? This was actually a very sweet 91-year-old woman who came to the emergency department. She got up in the morning and was feeling fine. And as she's been doing for the past 70 years, she made herself some bacon, some eggs, ate her breakfast, took her morning medications, of which there are 12. And 2 hours after taking her medications, her tongue started swelling, and she came to the emergency department. This is a very scary picture for emergency providers and anesthesiologists, because not only can the tongue swell outside of the mouth, it can also swell backwards and occlude the airway. So this is an emergency that, in which the airway needs to be protected. Fortunately, this is not a very severe case of angioedema. There are much worse cases than this. But looking at our medication list, we have to find which culprit medications could have done this. Unfortunately, there is more than one on there. So the first one that I zoned in, it's the lisinopril, which is an ACE inhibitor, and we know that these medications can cause this. Unfortunately, for lisinopril, this does not occur with the first dose. Patients can be on this medication for years. Actually, the median time to presentation is between 10 to 36 months after starting the medication. So these patients can be on the medication for years before this complication develops. Another one that can cause it is aspirin. And we said that's a good medication. Citalopram, rarely. Hydrochlorothiazide, ibuprofen as well. So we have a very elderly patient with many comorbid conditions for which she takes medication, and we have to take into account, if we discontinue these medications, that we have to replace them with something else. But this is what kind of mild to moderate case of angioedema because of an ACE inhibitor looks like. So in short, if you come across somebody who's having an allergic reaction, where they have a severe rash, difficulty breathing, the one thing to remember is to call 911. And the reason we say is to call 911 is because when the ambulance arrives, the ambulance actually has epinephrine on board, and that can be initiated right in the field. We don't want patients to actually drive themselves with severe allergic reactions because they can get stuck in traffic. And allergic reactions can be very unpredictable. They can go from a minor rash to patient not being able to breathe very, very quickly. So if you yourself are experiencing an allergic reaction, or you come across somebody who is having an allergic reaction, the safest thing to do is call 911 or contact EMS. So moving on, let's talk about adverse drug events in the actual community. So this is a study that was done by Dr. Sarkar, actually at San Francisco General Hospital, and she looked at data between 2005 and 2007 of a large database for ambulatory patients. And basically what she found is that about 3/4 of the patients who have an adverse drug event will seek care in an ambulatory setting. They will go to their primary care provider. About 1/4 of those patients will come to the emergency department. Why do patients come to the emergency department for adverse drug events? One, it's likely that those adverse drug events tend to be more serious, or two, if the physician office closes at 5 p.m., these patients will come to the ED to seek their care. Interesting find by Dr. Sarkar was that if the patients are older than 65 years of age, they were 3 to 4 times more likely to have an adverse drug event than patients who are between 25 and 45. They also found that patients with no insurance were less likely to have an adverse drug event, although we have to be careful with this because if the patients, they probably have just as many adverse drug events, but they do not seek care due to cost and access constraints as patients with insurance do. And one of the best predictors from this database, what she found, was that the medication burden, meaning how many medications the patient is taking, is actually the best predictor of the patient developing an adverse drug event. So let's kind of zone in and look at a specific patient population. In this case, it's going to be adverse drug events in patients older than 65 years of age. And why are we specifically looking at this cohort is because patients greater than 65 years of age, about half of them take between 5 and 9 medications every day. 18% of them take 10 medications or more. So quite a bit of a chance for drug-drug interactions and inappropriate use of medications. We know that with age, there are certain physiologic changes that happen. Patients become more frail. And the way that the drugs behave in a frail body is a lot different than how they behave in a 25-year-old. Many patients have comorbid conditions. And we know that they use what we call polypharmacy, or many medications at once. All of these are risk factors that lead to adverse drug events. So in this study from New England Journal of Medicine, they found that there were about 250,000 ED visits for an adverse drug event per year. About 38% of these required hospitalization, meaning the adverse drug event was severe, that the patient had to be admitted to the hospital for treatment. and half of those patients that were admitted to the hospital were 80 years of age and older. Which adverse drug events affected this patient population? Unintentional overdose was the most frequent one, followed by adverse reaction, allergic reaction, and other miscellaneous reactions. If we look at the actual drugs themselves to see which one of them are implicated in adverse drug events, the first on there is the blood agents, and kind of the most common one is warfarin, something that Dr. Kaiser talked about a couple of weeks ago, leading to bleeding complications, followed by endocrine agents. The most common ones are insulin and oral medications used for hyperglycemia or diabetes, followed by cardiovascular drugs and drugs used central nervous system, things like antidepressants and benzodiazepines. So we looked at the greater than 65 years of age cohort. Now let's look at those patients on the other spectrum, which are kids. And by definition here, the kids is anybody less than 18 years of age. And I was very surprised to find that 160,000 ED visits for an adverse drug events happen per year. And there are some statistics about medication use in kids, and medication use is actually increasing. 50% of kids less than 18 take one medication every day. And today there are many conditions, even cancer, that can be treated by oral agents, oral chemotherapy agents in the outpatient setting, which can lead to adverse drug events. 7 out of 10, the most commonly used medication in kids are over-the-counter, meaning parents can buy these medications without a prescription. So what we found is that, what this study found was that kids between 1 and 4 years of age accounted for 50% of patients seeking emergent care due to an adverse drug events, quite a bit less than the elderly patients. 10% of these kids required hospitalization. The most common themes were unintentional overdose, allergic reactions, quite a bit of those, and other adverse effects.
What's the most common allergic reaction?
The question is, what's the most common allergic reaction in kids? So that is the next slide. It's a great segue. Absolutely. So the class of drugs that were most commonly implicated were antibiotics, and with allergic reactions, it was the antibiotics that caused this. Now, almost 50% of these cases involving antibiotics and allergic reactions were for a drug called amoxicillin, which is a very old drug and a very effective drug, and probably the most prescribed antibiotic for in kids. And Dr. Guglielmo talked about judicious use of antibiotics. And one of the things that we can talk about is whether the judicious use of antibiotics, meaning prescribing them only when appropriate, because as we know, viral diseases are not treated by antibiotics, but do put patients at significant harm. So for example, if the patient comes in and they're having signs of an ear infection, and the provider provides antibiotics where they didn't need to, so this patient's now being exposed to the adverse drug event, which could be rash, without actually any benefit of treating the underlying cause. So antibiotics were the most commonly ones implicated, followed by analgesics, acetaminophen, Tylenol, or paracetamol outside of the United States, and ibuprofen. And there were quite a bit of cases of unintentional overdoses by kids getting into medications and other substances in the house. And a few years ago, well, actually decades ago, child safety caps were starting to be introduced on all prescription medications. And what they found that some people will say that there was about 50% decrease with unintentional overdoses, resulting in child mortality since that change. So if you do have children at home and you yourself take medications, please do take some precautions. Store the medications away from the kids. If you do have medications, make sure that there's a safety cap on them so kids cannot get into it. And please, 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 if you're not using medications anymore, you have to discard them so they're not laying around the house. The question is, how do you get rid of medications? And there are many different ways. There are drives and local events where we will collect medications and dispose of them. Also, FDA has a great website on how you can dispose of these medications at home yourself. So, all of the things that we talked about so far have involved looking at large databases and kind of thinking about what could be contributing to these adverse events and why they are happening. So these database studies do answer that medications, adverse drug events are happening, but what they don't answer is why these things are happening. So one of the things that we use in hospital to determine when there's a bad event, an event that they call never event, something that should never happen because it was preventable, they do what's called a root cause analysis. And the way that it's done is that all the information is collected together with the people that were involved with an error or an event. And there's a cost charting, and there's a lot of debate, and we decide which things we can focus on and improve so this thing never happens again. So a very common practice that's done in hospitals, but it's not commonly done in the outpatient setting. So that's what we try to do, and that's what our study was about. And we looked at patients that came to the emergency department, and we decided to enroll them in this study. And basically, the clinical pharmacist would identify these patients that is having an adverse drug event. After 2 weeks, we would call the patient at home to see how they were doing, and also their prescriber, so whoever prescribed the medication, and we would give them a set questionnaire, ask same questions of all of them, and later we would collect all this data and try to find out what contributed to this adverse drug event. Like we said, this is done quite frequently in the inpatient settings in the hospital, but it's not done in the outpatient setting, especially taking into account the patient's perspective on an adverse drug event. So our results, we screened about 63 patients in a short amount of time. We excluded 22 patients. We did have an alarming number of pediatric cases that had an adverse drug event, about 11 of those. 6 patients, we enrolled only patients that spoke Spanish or English, as our research assistants only spoke those 2 languages. 4 patients refused consent, and we enrolled 1 patient by mistake who was a skilled nursing facility patient and not an outpatient. At the end of that, we had 41 patients that we were working with. So what did we find? Our results resembled pretty much the large database studies, in that for adults, we found that the anti-diabetic agents, things such as insulin and oral hypoglycemic agents, were number 1 on the list, followed by warfarin, the anticoagulant, and then followed by antibiotics. So even though our cohort was very, very small, we were starting to see the trend of reflecting these large database studies. When we further looked at these patients, we found that out of 41 patients, only 1 patient was taking just that 1 medication that caused an adverse drug event. 40 other patients were taking multiple medications. And what we found is that in half of those patients, they had significant drug-drug interactions, meaning that their medication regimen had drug interaction, which could have contributed to them getting that adverse drug event and coming to the emergency department. And those patients, on average, took about 7.5 medications every day, versus those patients that didn't, they took 4 medications. So what do we find when we talk to the patients and the providers? So looking at 1 case which involved insulin and hypoglycemia, very low blood sugar, when we call this patient, and mind you, this is somebody that's been on insulin for 3 years, this is what she said about the event. I still don't know what causes low blood sugar or how it comes on. They showed me about eating. I should eat first, then my shot. Before it was my shot, then eat. I don't know which one is right. Which kind of has a few red flags here. One of them is that this patient's been on this regimen for a very long time and still unclear on how to use this medication. So there are patient education issues here that could be solved just by providing this patient with the correct information. If we look at the next case, which is a warfarin case, the anticoagulant case, this was a patient who was on warfarin, who had a fall, and she bled into her chest cavity, causing what's called a hemothorax. And when we called the prescriber, they told us the big thing about this would be going back to Coumadin with a warfarin and thinning out the blood in someone this age. And as you know, high fall risk and injury risk, but you were, and given her medical history, there was a need for anticoagulation. which brings up a few other points, is one, that these patients have multiple comorbidities. They may be have had a stroke or maybe a heart attack, diabetes, depression, and we're trying to treat all of these things simultaneously. And by treating them, we can actually expose them to harm, such as this patient. And this is a very difficult thing for primary care providers to weigh the risk and the benefits, especially in elderly patients, between all of these comorbidities that they're trying to treat at the same time. The next medication was niacin, which is a vitamin that can be bought over the counter or by prescription. The background to this story was that the patient was given a prescription for niacin, the extended release niacin, and he went to the pharmacy, and the insurance, not the pharmacist, said that we don't cover this medication, instruct the patient to get the generic niacin. But what ended up happening is the most common adverse drug reaction with niacin, which is severe flushing, full body flushing. So when we called this patient, this is what he told us. I took the cholesterol pill, meaning the niacin, and then it started with a lot of hives on my face, and before I knew it, it was all bumpy and swollen. My heart was racing, and when we asked them, did anybody tell you about that? Because it's a very common thing, and it can be easily prevented by taking an aspirin half an hour before the niacin. Patients stated no. So when we looked at all of these interviews, we provided a framework or three factors that we wanted to look at. The first one was the social and health system factors, the medication factors, and patient factors as well. So let's take a look how an adverse drug event happens in this cohort of patients that we studied. So let's start with a patient who had a dangerously low blood sugar of hypoglycemia. So this patient didn't eat in the morning, but she gave herself her insulin shots, went out to the street and collapsed. When the ambulance picked her up, her blood sugar was 28, which is very, very low. So if we look at our factors, let's look at the drug first. So the drug that was being used was insulin, and insulin is a drug that has a very narrow therapeutic index. Now, what that means is that the level of the drug in the body to provide treatment that we're looking for is very close to the level that can be toxic. So for example, if somebody takes 5 units of insulin, and that's working for them, and then by mistake, if they inject 10 units of insulin, which is an easy mistake that can be done, that can result in hypoglycemia. This patient was also on multiple other drugs that did have drug-drug interactions, which could have contributed to the hypoglycemia as well. Let's look at the patient itself. Few comorbidities, one of them being depression. So patient was started on antidepressants. Unfortunately, the side effects of antidepressants is that they cause weight gain. Once we have fluctuation in weight, it gets harder to manage diabetes. We have weight gain that worsens the depression. Now we're getting into a cycle, and the poor diabetes control when depressed. She doesn't feel like taking her medications or injecting insulin when she's depressed. Looking at social factors, this is a patient that runs out of money at the end of the month. She doesn't have a lot of support. As she runs out of money, she buys less food. The less food she eats, the more difficult it becomes to dose and titrate her insulin. And finally, when talking to the physician, they tell us that this patient is very complicated, both medically and psychosocially. There are many issues that are at play here, and simply there's not enough time to address all of them. And this patient also, due to insurance constraints, doesn't have access to diabetes medication and diabetes education. So now that we know, yes, hypoglycemia is an adverse drug event, there are many, many factors that contribute to this. And looking at this, we have to find actionable items, things that we can intervene on the outpatient. And for pharmacists, one of those things would be increasing patient education when it comes to high-risk drugs such as insulin and warfarin. So what else did we find? We found that the drug factors, these patients were on high-risk medications with very narrow therapeutic indices, such as warfarin and insulin. There were many drug-drug interactions and drug disease state interactions, and there was a lot of polypharmacy. And we know that 50% of Medicare patients receive 5 or more medications, so this is something that's very common in this cohort of patients. As far as patient factors, many of our patients were not aware of the side effects of the medications. And when we talked to them and we asked them, well, do you know what the signs and symptoms of hypoglycemia are? and they were not aware of that or how to look for those side effects. There was certain mistrust of the medical system by a few patients where they said, I went to the provider A, who sent me to provider B, who sent me to provider C, and none of you know what you're talking about, and I'm just going to deal with this myself, which resulted in an adverse drug event. Patient capacity understanding. For patients who have mild dementia, it's very difficult for them to balance 5 to 10 medications that they have to take every day. And like we said, patients with multiple comorbidities. And finally, the social and health system factors, what we found is access to care. Many of these patients ended up in the emergency department because they didn't have access to primary care. There was a lack of continuity, and there was a lack of communication. For example, there was a patient who had a history of seizure disorder that was referred to a provider to treat her depression, and these two providers did not exchange information. And the second provider started a medication that lowers the seizure threshold, and this patient seized because she was prescribed that medication, which could have been avoided if there was free flow of communication between those two providers. And finally, lack of social support. So after we talked about all of these adverse drug events, what are some things that we as patients can do to prevent adverse drug events, since they're very common? So first thing that we can do is tell the healthcare provider all the medications that you're taking. And actually, the best thing to do, the one thing that I really, really appreciate that patients do, is when they bring their bottles with them, because we can not only see what they're taking, and we can see if they're taken by looking at the pill count to see if they're compliant with their regimens or not. Bringing medications to your doctor office, hospital, get one pharmacy and have them keep a record of all of your medications. There's a lot of incentives to change pharmacies because they have promotions. This probably does more harm than good for patient safety. Let your pharmacist know all the medications that you're on, and every time that you get a new medications, please ask whether there's drug interactions with the new medications. Tell us your allergies and adverse drug reactions, because many drugs cross-react, and we want to know about this. And finally, well, actually, make sure you can read the prescription if it's still being handwritten. And when in doubt, ask. It's your right as a patient to know what's going on, which procedures you're receiving, and what medications you're getting. So with that, I want to see if there's any questions.
Well, the only other life-saving drug that I always have in my office was atropine for a vasovagal reaction and a preloaded syringe. And a couple of times, I think I probably, quote, good quote, saved a life because of the, severe bradycardia and whatever.
Yeah.
Just think.
Right. So the question was that one of the drugs that was used was atropine for severe bradycardia, and for a long time it was thought that atropine indeed is a useful drug during resuscitations, and it's still very useful for symptomatic bradycardia. However, the evidence, at least in emergency medicine over the years, has panned out that atropine, there's no benefit in the acute resuscitation phase. So in that case, it's not a life-saving medication, but for profound bradycardia, it can definitely improve symptoms and get the patient back. Thank you.